This slide's presentation covers various treatment options for Parkinson's disease. Essentially, Parkinson's patients can be treated pharmacologically. They have to take special care with nutrition due to some of the pharmacological management that's used. They are also candidates for surgery, namely deep brain stimulation. And finally, physical therapy is a viable treatment option for Parkinson's disease. So, common drugs for Parkinson's are listed on this slide. There's the category of drug known as a dopamine agonist. Okay, this dopamine agonist, an example of this kind of drug is bromocriptine, and it works by activating the dopamine receptor directly. It has various side effects that you should be aware of, and those include nausea, headaches, dizziness, fatigue, cramps, and confusion. Okay, another category of Parkinson drug is a dopamine replacement. And a common drug that most patients that I've worked with that have Parkinson's were on is known as Sinemet. Now, Sinemet is actually a combination of two different kinds of drugs. The first is carbidopa, and the second is levodopa. Carbidopa is actually an inhibitor of something known as dopamine decarboxylase. And if you look under action, DDC stands for dopamine decarboxylase inhibitor, which is the carbidopa. And dopamine decarboxylase is actually an enzyme that breaks down the second component of the drug Sinemet, levodopa, into dopamine. Okay, you don't want the levodopa to be converted into dopamine immediately after ingestion. So if you add the carbidopa, it stays as levodopa, which can cross the blood-brain barrier and eventually be converted into dopamine in the brain. Side effects. Probably the big one that you're going to see here with this patient population is Sinemet causes orthostatic hypotension. Okay, excessive amounts of Sinemet will also cause dyskinesias or various movements that aren't normal. They're drug induced. So just various twitches or muscle contractions that aren't normal and that aren't controllable by the patient. Can also cause nausea, dizziness, confusion, as well as hallucinations. Okay, another category of drugs for Parkinson's is an MAO or monoamine oxidase inhibitor. Okay, monoamine oxidase is something that causes the breakdown of dopamine, and examples of this type of drug are the selegiline and the rasagiline. Okay, side effects you need to be aware of are insomnia, dizziness, nausea, hallucinations, confusion, as well as headache. And finally, there are anticholinergics that are available for Parkinson's, and the anticholinergics function predominantly as a tremor-reducing drug, and they work by blocking acetylcholine action. Common drug that you might hear is known as Artane. With the anticholinergics, you should be aware that the patient might complain of dry mouth and eyes, constipation, memory impairment, confusion, depression, as well as hallucinations. Okay, Sinemet, the main drug that most patients with Parkinson's are on, it has an off time and an on time. Okay, when the drug is actively working, that means that the patient is on. And this video shows some really good examples of freezing of gait. Okay, or going from the floor over the carpeting. This is his off phase, so he is not currently on medication, but just walking over that little piece of carpeting caused him to freeze. And turning. Very different and difficult in this patient population. Okay, this is external focus is going to help. Visual cueing. So having him, and then there's auditory rhythmic cueing. Even though he's not on medication, this helps considerably. It's an external focus of control. Okay, this is on medication. Big difference. So, you should be aware of the fact that the patient with Parkinson's who is on Sinemet should not be eating a high-protein diet because it can block the effectiveness of the dopamine replacement. And the biggest dopamine replacement drug you're going to hear about is Sinemet. It is recommended they have no more than 15% of their calories from protein, and in addition to this, that they shift their protein to the evening meal to maximize the absorption of the drug in the bloodstream. It's also recommended that they eat a variety of foods and supplement when needed to ensure proper nutrient intake. And they might be appropriate, or they might need occupational therapy to help with their eating, and they might need speech therapy or speech language pathology for dysphagia. Okay, as far as surgical management is concerned, these patients may be eligible for deep brain stimulation. And we talked a little bit about deep brain stimulation and neuroscience, and essentially there is a transmitter or electrode placed in the brain, and you can see that on the top right-hand side picture, that the electrode is specifically stimulating the subthalamic nucleus. Deep brain stimulation is really good for patients that are tremor dominant as opposed to postural control dominant. There is a very low morbidity, but there are some psychological problems that can appear after this kind of surgery, and these include depression and mania. But actually, after the implantation of the DBS system, the relief of symptoms is very quick. And here's a quick video just showing the difference between before and after deep brain stimulation. And again, just some finger nose to give you an idea of the extent in the change with this individual's tremor. In addition, there's physical therapy for Parkinson's. And the kind of therapy that we're going to prescribe for patients post-Parkinson's is really going to depend on the stage of Parkinson's that patient is in. This slide has a nice table that breaks down what kinds of things we would do with patients in early, middle, and later stages of Parkinson's disease. Okay, so in the early stages, you definitely want to establish a baseline of function and track progress over time. You're going to design an exercise program that includes aerobic, strength, balance, and stretching exercises. We'll talk more about this when we talk about the clinical practice guidelines for Parkinson's. In the early stages, maximize fitness and mobility and get that person moving. The more they move, the better off they're going to be. You also want to provide guidance and access to community resources such as a YMCA would be helpful. Any kind of group fitness program would be really helpful, especially early stages. There's something known as rock steady boxing. Excellent for patients, especially in early stages, just to get them moving and to get them a community to exercise with. In the middle stages of Parkinson's, you want to make sure that the exercises that you use have a high level of intensity and focus on highly intense balance exercises to help decrease falls in these middle stages. You want to emphasize functional activities such as getting in and out of bed, getting up from a chair. You want to work on things that might help with freezing of gait, and we'll talk about some strategies you can use there at the end of the slides presentation. You also want to introduce the concept that listening to music or using some sort of visual cue can help make moving easier. The concept here is that Parkinson's patients, they focus so hard on the actual movement, they can't walk because of it. But if they take the focus away from the internal concentration of moving and have an external focus, then the movement becomes much easier for them. In the later stages, you definitely want to help a person and fit them for specific assistive devices that might help with their mobility. You can do home modification or suggest home modifications that will help with the patient's mobility, as well as definitely want to help caregivers learn how to handle the patient properly and help them with functional mobility. Okay, as I mentioned, there's a clinical practice guideline, and that's associated with this section. Here's the summary. So you can see from this summary that the strength of recommendation and the quality of evidence is high for the majority of things on this list. Interestingly enough, there is low quality of evidence and therefore a lower strength of recommendation for flexibility exercises. Okay, boiling this all down, as far as aerobic exercise is concerned, according to the CPG, the recommendation is moderate to high intensity aerobic exercise to improve oxygen consumption. Okay, it's going to reduce the motor severity of the disease and improve functional outcomes. This is recommended for mild to moderate, which would be considered Hone and Yar stages 1 through 3, as well as those with balance deficits. The Hone and Yar stages 3 through 4 should use a stationary bike to reduce the risk for falls. Okay, the fit frequency is going to be 3 times a week. Moderate intensity, 60 to 75% maximum heart rate. Too high, 75 to 85% maximum heart rate for 30 to 40 minutes. And you can use either stationary cycling or treadmill walking. Okay, as far as resistance training, the recommendation is resistance training to reduce motor disease severity, improve strength, power, non-motor symptoms. Remember, there's quite a few of those, as well as functional outcomes and quality of life. It's appropriate for all stages of Parkinson's, or stages 1 through 4 specifically, but those with balance deficits, so stage 3 and 4, would require supervision and might need modification of some of the exercises to make it more appropriate. Okay, frequency or fit dosing is going to be 2 non-consecutive days per week for 30 to 60 minutes, and you can use strength or you can use power. There's a lot of systematic reviews that have been coming out talking about the substantial effect of power training to help patients with Parkinson's. Okay, and you can use either weight machines or free weights or resistance bands, depending on the strength of the patient. But you definitely want to hit the right intensity. Other rehab options. Okay, these are all recommended in the clinical practice guidelines, and that would be external cueing using visual, auditory, or amplitude, and amplitude would be large movements, very large movements, because for Parkinson's patients, they think everything is normal size, but if they want to get to normal size, they have to think large. And there's also something called LSVT training for Parkinson's, which is Lee Silverman's voice therapy. And the motto for Lee Silverman's voice therapy is big and loud. I mean, have these patients scream and make large amplitude movements. It's also community-based exercise is recommended in the clinical practice guidelines. And here in this slide, you see the rock steady boxing. I mean, these are all, imagine having a patient with Parkinson's try and hit a speed bag or use a heavy bag or handle ropes. I mean, they're really great exercise program for somebody with Parkinson's. Also recommended would be gait training, and this would be one-on-one gait training with the therapist, as well as task-specific training. So if the person's having trouble with sit to stand, teach them how to use sit to stand. And again, low quality of evidence for flexibility exercises, but you definitely want to maintain flexibility to help prevent contractures and future problems. Then finally, as I mentioned previously, here's some just general tips for freezing of gait. So as the person's trying to walk along, instead of concentrating so hard on taking that next step, have them try another movement. Okay, have them just stop walking and raise their hand. Put their attention on raising their hand or touching their head or pointing to the ceiling, whatever, and then try again. Okay, so you take the focus off the internal concentration for taking that next step, put it someplace else for a minute and try. If they can't go forward, change direction. You can try sidestepping or, maybe taking a step back and then go forward. Another one, a laser pointer seems to work really well. Okay, so if a person has a laser pointer and you point it in front of them, if you have them not concentrate on taking a step, but step on the laser light in front of you, that works really well. And interestingly enough, there are some canes as well as rolling walkers that have a laser line that you can step over, and that seems to make a big difference for freezing of gait. Again, similar strategy. If you visualize an object on the ground, try and step over it. Okay, so instead of taking the next step, step over what you see, external control. Wear a metronome. Okay, try humming and restart with the beat of the music, taking your mind off the action of walking. Stop walking, count to 3, say go, and just go. No thought involved, just start moving. Weight shift side to side. You can march in place a few times, and you don't want to try and fight your freeze by trying to step harder. The trick to all of these tips is going to be to shift your attention away from moving your arms and your legs. Okay, you just want to stop thinking about trying to do that and shift the focus externally.